Welcome to everybody. Although we are going to address quite a sensitive issue of violence against women and girls, I'd still like to take the opportunity just to wish everybody a happy International Women's Day. So I think it's important that we recognise all of the good things and the achievements that we've had. My name is Nadine Farris France. I'm the Operations Director for the Irish Forum for Global Health. And on behalf of the Irish Forum for Global Health and the the Joint Gender-Based Consortium, you're very, very welcome. The Irish Forum is a network that brings together over 600 members who are interested in global health in Ireland and around the world. We work on policy and advocacy, education and research. And Jim, I think, will say a little bit more about the Gender-Based Violence Consortium. But it's also a consortium that brings together over 15 agencies, all looking at making sure there's a coherent response to gender-based violence. So without further ado, I'd just like to introduce you to our chairs for the day. We have Jim Clarken, who's the CEO of Oxfam and also the chair of the Gender-Based Violence Consortium Steering Committee. And we have Dr. Eilish McAuliffe, who's the director of the Centre for Global Health in Trinity and also one of the founding members of the Irish Forum for Global Health. So Jim, I believe you're going to say a few words as well. Thank you.
I'm Jim Clarken. As said, I'm the chair of the Joint Consortium on Gender-Based Violence. And this is an Irish organisation comprising rights, humanitarian and international development agencies, along with Irish Aid and the Irish Defence Forces. So it's a unique vehicle, we think it's unique in the world, in fact, where civil society and government work very closely together and work very effectively together. And we're very fortunate to have Mary Robinson as our honorary patron. And the purpose of the consortium on gender-based violence is to work collectively to promote the adoption of coherent and coordinated response to gender-based violence in our own work and as well as influencing others to do so. So it's an important group and works very well, we think, and we're continuing to develop and expand the scope of that work. Today's event is about casting a specific focus on the health and social consequences of violence against women and girls. We know that the global statistics regarding GBV are startling. Say 1 in 3 women will experience physical or sexual violence from men, usually someone they know in their lifetime. The situation is particularly chronic in the world's poorest countries. A study by the International Centre for Research on Women found that a shocking 80% of women in Uganda and 94% in Bangladesh had experienced physical, sexual or psychological violence at some point in their intimate relationships. Every year 60 million girls are sexually assaulted either at school or on their way to and from school. And even though domestic violence is now outlawed in 125 countries globally, there are still more than 600 million women who are not protected by the law in their own country in relation to domestic violence. And even where the law is there to protect women, it exists in many countries only on paper and it is not enforced. So clearly GBV or gender-based violence is a rights issue, but how is it a health issue? Gender-based violence is one of the major causes of death, disability and ill health in women. And just to give some examples of how that manifests itself, women who've experienced violence are up to 3 times more likely to suffer from HIV or to be living with HIV. GBV makes it harder for women to negotiate for safer sex or to leave partners who engage in high-risk behaviour. More than 130 million girls and women have been subjected to female genital mutilation, with potential impacts including long-term gynecological health problems, infertility and complications in childbirth. The impact of gender-based violence on maternal mortality is significant, where partner violence, particularly in pregnancy, also results in increased infant and fetal death and low birth weight, setting up health impacts going on into the future generations. The psychological impact is also very significant, with women often exhibiting post-traumatic stress disorder, depression and other mental health issues. So the health implications are extremely wide and very deep and affect so many women. But as well as the direct health impacts of gender-based violence, we know that it prevents women's basic needs being met and their rights being realised. It's harder for women to earn a living, to work to produce food, to play a healthy and active part in their community and to access education. a lack of control, or the shame that a female victim may herself feel can make it harder for women to seek out and to access health services when they need them. But if gender-based violence has health and social consequences for women, it also has indirect impacts on children and men too. It not only keeps women poor, but it keeps whole families, communities and countries poor, because women have such a crucial role in providing the food and other resources to the household and to the whole community. This suppression of the potential of women has impacts for everyone. Violence against women therefore acts as a significant impediment to overall development. So as development practitioners, it's a key focus for all of us. By limiting women's choices and ability to access education, to earn money or to participate in political and social life, gender-based violence is a key factor in preventing the progression from poverty to development. It is a pandemic that can only be resolved by the participation and commitment of women and men, and ensuring that we, as an international community, invest sufficient resources and energy in solving this issue. So it is up to everybody. We all have a stake to play in. There aren't enough men in the room here today, but we very much encourage the active participation in men. It is up to us to solve this problem working with women. So that's just a brief intro onto the overall theme for the day. I'm I have great honour to introduce Avni Amin, who's our first speaker. She's a technical officer with the Department of Reproductive Health and Research at the World Health Organization in Geneva. She works in the Sexual Health, Adolescence, Gender and Rights team and oversees a portfolio of work on gender, gender-based violence and HIV linkages. She has a PhD in International Health from the Johns Hopkins University School of Hygiene and Public Health in Baltimore, USA, and she has 18 years of experience in the field of gender equality, sexual and reproductive health, and including HIV. And she's going to speak to the broad issues and also to delve into them in a lot more detail. So Avi, would like to welcome you.
Thank you. I just wanted to start by thanking all of you in advance for your patience to listen to the presentation, but also particularly I wanted to thank Nadine, the Irish Forum for... Okay, thanks. The Irish Forum for Global Health, the Consortium for Gender-Based Violence, as well as all the partners that have put this event together. And it's a real honor and a privilege to be here today. Particularly because it's International Women's Day and there's a special theme focusing on girls. So really, I'm delighted to be here. I'm going to be talking about violence against women and children with a focus on girls. And I'll be sharing some of the data that we have, both on the magnitude of violence as well as the health impacts. And then I'll also talk a little bit about what we're beginning to know about effective strategies to respond to violence and to prevent violence. I just wanted to start by acknowledging my colleagues and a lot of people who've been working on these issues from a data point of view. Particularly, I wanted to start by thanking Claudia Garcia Moreno, who is the coordinator for our team in WHO, as well as Cristina Palito, who's a colleague of mine, who has actually been, both of them have been doing a lot of the data analysis and the data work around violence against women. I also wanted to thank the colleagues from the London School of Hygiene and Tropical Medicine. There's a global burden of disease expert working group on violence against women, and both WHO and London School are part of this team, with Claudia being the chair and Charlotte Watts from the London School being the co-chair and Karen DeVries is the coordinator. And these are the people who are responsible for a lot of the analysis and the data that you'll be seeing that I'll be presenting. Yeah. Just in terms of the outline, I'll start by describing what we know about the magnitude of violence against women and girls. I'll talk a little bit about the health consequences, but also some of the broader socioeconomic consequences with a focus on some of the intergenerational impacts that violence has, and that has obviously implications for the future of children, for girls, and families. I'll also talk about the risk factors that for violence against women and girls. I'll talk a little bit about the prevention and response in terms of the evidence, and then just maybe if there's time, I'll go into some of the work that we're doing in WHO. Some of the main data sources that we'll be using, the first one is the forthcoming analysis on the global burden of disease estimates for violence against women and its health impacts. And this is analysis that is really hot off the press. Some of it is not yet complete, so it's the latest data. I'll also use some of the WHO multi-country study on women's health and domestic violence. This was surveys that were done in 10 countries, and it was released, the first round of the data was released in 2005, but there's been subsequently, we've done a lot of additional analysis from that data that I'll share. I'll also share some of the data that's coming out of the demographic and health surveys, which are surveys conducted by the US government. And they have a domestic violence module, so they're also beginning to analyze this data. And there's a forthcoming analysis of violence against women in 12 countries in Latin America and the Caribbean, which our regional office in the Americas is doing an analysis. So some of that data also I will present. So I just wanted to start by building the narrative around some 4 or 5 key messages. And the first one that we are, I think pretty much everybody recognizes that it's a widespread problem, it's a public health problem and a human rights violation. So I think we're all sort of at this stage in agreement with this particular key message. But what is the evidence behind that? Just in terms of starting with some basic definitions so that we're all sort of on the same page with how the UN and we have defined gender-based violence and violence against women in some of the analysis. The first one, I'll just start with the use of the word GBV, the acronym GBV or gender-based violence. And it really is derived from unequal power relations between men and women. It includes acts of physical aggression and harm. So we have definitions that include things like hitting, slapping, pushing, shoving. That's how we measure it. Emotional, psychological abuse and controlling behaviors. And then there is coerced sex, sexual harassment and rape, which is part of what we call sexual violence. Now, violence against women is part of the definition of GBV, and it's really emphasizing the fact that majority of the violence that's perpetrated, majority of the gender-based violence that's perpetrated worldwide is perpetrated by men against women. So that's why sort of the focus and emphasis on violence against women. And that's sort of defined as public or private act that results or is likely to result in sexual, physical or psychological harm to women. There are different forms of GBV or violence against women, and I've sort of bolded the first 2 to highlight the fact that we won't have time to go into all the different forms of violence, but that I'll be primarily talking about the first 2 forms, which is intimate partner violence, sexual, physical or emotional violence by an intimate partner, to some extent where there's data also by non-partners. And then I'll touch upon child sexual abuse and child maltreatment, and that includes violence against children, adolescent girls and young people. The issues of sexual violence and conflict, forced prostitution and sexual trafficking, child marriage, female genital mutilation, and then homophobic violence are things that are considered as part of the definition of gender-based violence, but we're not going to be touching upon them today. So this is the some of the forthcoming data from the global burden of disease. This is sort of the estimates of violence against women, combining 3 sources of surveys. The first one being the demographic and health surveys, which are conducted in over 25 to 30 countries, focusing specifically on the violence module. And then we have the International Violence Against Women surveys, as well as the WHO multi-country study. And if you can sort of see, you'll see just in terms of the gradation of the colors, the lightest pink being prevalences of between, well, less than 5%. And that sort of darkest maroon brownish shading being where prevalences reach about 64%. And you can see where some of the countries are, where the highest prevalences are, and that's primarily Eastern, Southern Africa. And some of the lightest sort of gradations are, you can see data we have from Australia, North America, as well as from some of the Western Pacific nations. Japan is another country where we have some data from, as well as some of the European countries. This, I just wanted to flag some of the data that we've had from the multi-country study that was released in 2005, which again sort of breaks down by country for two dimensions. The first is lifetime prevalence, or prevalence that women experienced ever in their life, and prevalence that women experience most recently, and that most recent period is defined as a 12-month period, or the last 12 months prior to the survey. So you can sort of see that in Ethiopia, on one hand, both lifetime prevalence as well as recent prevalence is fairly high. It's sort of reaching 70%. I mean, it's endemic from a public health point of view. And then you have Japan on the other end, where it's about 4% and about 10% for lifetime and 4% for recent. I just thought that I'd share with you the data from Ireland. This is data that we are going to factor into the global burden of disease estimates. And these are from two surveys, cross-sectional surveys that were done in 1995 and 2003. The first one being prevalence of sexual violence from the intimate partner, which is a lifetime ever. And that in the 1995 survey was 4%. In the 2003 survey was 8%. The prevalence of any physical violence, again in the lifetime, in both the surveys was about 10%. And then they also included measures of severity, which is based on the impact it's likely to have on physical health, mental well-being, and injuries. And that is 1.5% in 1995, 8% in the 2003 survey. And then severe physical violence being 2% in the 1995 survey, and 2003 survey, it's 13%. So this is what we have so far in the published that we are using for the global burden of disease estimates. Then just talking a little bit about violence against children with a focus on girls. The first sort of overall definition is around child maltreatment, abuse, and neglect of children under the age of 18. And that includes all types of violence, physical and emotional ill treatment, sexual abuse, any kind of neglect, negligence, commercial or other types of exploitation of children. And this particular sort of, the data for child maltreatment and child abuse is very, very difficult to get. What we have are estimates, and what we know from the estimates, global estimates, is approximately 20% of women, when you ask women about their childhood experience, and then 5 to 10% of men report being sexually abused as children. And when you ask children, it's 25 to 50% of children reporting being physically abused. So there's a slight discrepancy, but when you ask adults about their previous history of childhood sexual abuse, and when you ask children. And when you sort of break it down for specifically for sexual abuse, you can see that it's much, much higher for girls. You have non-contact sexual abuse, which is sort of in the realm of, internet pornography, pedophilia. That is about 3% for boys, 7% for girls. And then you have contact sexual abuse, 4% for boys, 13% for girls. And then you have the penetrative sexual intercourse abuse, which is 2% for boys and 5% for girls. And when you combine all of that, then it's any type of sexual abuse is 9% for boys and 25% for girls. In terms of, again, if you wanted to look at prevalence of childhood sexual abuse when you ask children, and again, here is the data that we have from the multi-country study, the WHO multi-country study. When you look at country-specific estimates, you see that it's very, very high. In Namibia, for example, about 21% reporting sexual abuse before the age of 15. And then on the other end, you've got 1% in rural Bangladesh, about 2% in Samoa. And then sort of a range of prevalences in other settings. Now, this data are from surveys that are being done by UNICEF and CDC. They're being done in several countries. They're the violence against children or violence against girls surveys, and these are being administered to children from 13 to 24 years of age, both boys and girls in some countries, and specifically girls in some other countries. And this is data that has just come out from Tanzania. The survey was done in Swaziland. Other countries where this is being repeated is Kenya, Zimbabwe, Malawi, and Haiti. So this is asking children about their current or past experience of sexual and physical violence. And you can see in the top graph, you see that the prevalence of sexual violence as reported by 13 to 24-year-olds ever in their childhood is about 28% for girls and 13% for boys. And if you look at physical violence, it's an amazing, stupendous figure of 73% for girls and similar percent for boys. And then when you look at the same figures, same survey that was done in Swaziland in 2007, you look at the prevalence of sexual violence among girls aged 13 to 24. And here you have three specific statistics. The one is as reported by girls prior to the age of 18, that is when they were children. And then there is lifetime of violence as well as 12-month. And this is sort of disaggregated by very young adolescent girls, 13 to 17, the young sort of 18 to 24, and then together for 13 to 24. And you can see that for lifetime of violence, sexual violence amongst 18 to 24 years is almost 65 to reaching about 70% in Swaziland. So having gone through some of the data on the prevalence and establishing that this is a very significant problem both among women, adult women, as well as girls and children, we look at what the health consequences are. And so the second key message is really around the fact that it has multiple health, social, and economic consequences, not just for the individual, but families, as well as communities and societies. So what is the evidence for that? I just wanted to start by putting out this table to look at sort of the kinds of outcomes, the health outcomes we've been looking at. The first sort of the column here is the fatal outcomes, which is death, suicide, AIDS-related mortality, maternal mortality. And then you have the non-fatal outcomes, which are divided between the physical health outcomes, such as fractures, injuries, chronic pain syndrome, gastrointestinal disorders, some of the sexual and reproductive health outcomes, such as STIs and HIV, unwanted pregnancy, unsafe abortion. And then on the other hand, we have a whole range of psychological and behavioral outcomes such as depression, eating and sleep disorders, drug and alcohol abuse, self-esteem, post-traumatic stress disorder, increased sexual risk-taking, smoking, and perpetrating or being victims of violence later on in life. And this is specifically violence experienced by children and adolescents. So just to look at the associations between violence and attempted suicide, this is data from the WHO multi-country study from 10 countries. And what you see are the dark black bars, the higher bars, are women who had attempted suicide, or amongst those who had contemplated committing suicide according to the experience of violence. And you see that the black bars show that women who did experience violence, both physical or sexual, had much higher rates of attempted suicide. And here are some quotes that we have from the WHO multi-country study talking about sort of the impact that violence had on their lives, on their mental well-being. So one being from the woman in Bangladesh, where she says, "Since I got married, I was sexually harassed and abused by my brothers-in-law in many ways. And even if I'm not to blame for this, my husband severely abuses me because of this. Once he almost killed me by driving a knife into my throat and injuring me deeply." And then there's another quote from a woman in Peru. "I don't feel well, I just cry. There are times I want to be dead, and I even thought of killing myself or poisoning myself and my kids, because I think if I've suffered that much, how much would my kids suffer if I'm no longer there?" This particular slide is data that we have been analyzing from the WHO multi-country study that looks at the sexual and reproductive health outcomes of violence, and that is associations between violence against women and unintended pregnancies or unwanted pregnancies, as well as pregnancy loss, which includes abortion, stillbirth, or miscarriage. And what you see is that women who experience violence, there's an increased likelihood of them having an unintended or unwanted pregnancy. The risk for unsafe abortion increases threefold. The risk for stillbirth or miscarriage increases 1.5-fold. and pregnancy loss in general, there's a twofold increase. And this is sort of data from 10 countries. We are doing a similar analysis using data from the Global Burden of Disease estimates, which will give a much more updated analysis across many more studies. And this is just a quote from a woman interviewed in Brazil, where she says, "I was pregnant and he would always get home drunk. My daughter was sick and I complained that he hadn't brought the medicine. He beat me very much. I tried to escape, jumped a very high wall and knocked on my neighbor's door. I don't know how I miscarried." And we have a lot of data from the multi-country study that shows very clearly that there's a very high level of violence during pregnancy, even though people would think that during pregnancy violence would go down. This is data that is just going to the press now, and this is associations looking at violence against women and STI and HIV risk, which is basically about 41 to 45 studies from all settings, sub-Saharan Africa, Caribbean, Asia, and it's across all HIV epidemic types, which is both generalized epidemics as well as concentrated. And you see the black line in the middle is if the risk or the odds of association are 1. And then you have the plots here, all of these, which show the increased risk for STIs and HIV if you have experienced intimate partner violence. And when you pool all of this data, both from this as well as this graph here, you see that across all settings, women who have experienced violence are twofold more likely to be at risk of STIs and HIV compared to those with no violence. Looking at some of the health impacts for violence against children or violence against girls, you see this is the data from Tanzania, and you see that both boys and girls, but this one specifically is reported by girls who experience violence in their childhood, are much more likely to report poor health, feelings of depression, feelings of anxiety, as well as suicidal thoughts. And in terms of risk behaviors, you see this particular graph shows, and the red bars for both girls and boys shows that there's multiple sexual partners in the previous 12 months is much higher for girls who've experienced violence compared to girls who've not. Likewise for boys. The red bars are for those who've experienced childhood sexual violence, and the gray bars are for those who've not. So what do we know about some of the consequences other than health? Health of the individual? We know that if you've witnessed violence growing up in your family, if you've experienced childhood sexual abuse, that you have higher rates, the woman has higher rates of infant mortality, the children have behavioral problems, there's anxiety, depression, and suicide amongst the children, poor school performance, and then you have the intergenerational perpetuation of violence, which is that the children who grow up watching their mothers being abused or fathers perpetrating abuse are much more likely to perpetrate violence or experience violence as adults. And then children of women who've been abused are much more likely to experience physical injuries or health complaints, and then later on in life lost productivity. For the families, you also see the inability to work, the lost wages and productivity, housing instability. And then you have the social and economic costs, which are costs incurred by the victims and families, both in terms of costs for seeking healthcare, social costs, and justice. And then the perpetuation of violence and the cost to employers. And here, I was going to share with you, if we had time, some of the economic costs of violence that we were getting some data on economic costs to countries in terms of costs of healthcare as a percentage of GDP in some countries, but maybe later I can touch on that. So what is then the key message 3, which is what do we know or understand about the risk factors for violence? And one of the main sort of findings from a lot of the analyses that's been done on risk factors and underlying determinants is that it is rooted in gender inequality, and that traditional gender norms held by women and men perpetuate violence against women. So what is the evidence? This particular graph is from a risk factor analysis paper that was done with a multi-country study that was published in 2011. And when we looked at multivariate analyses of risk factors for intimate partner violence, the ones in red are the risk factors, the ones in green are the protective factors. And what we know, and the ones that are sort of highlighted in deep red are the ones that are the most significant. The first one, as I said, is the history of abuse. That is watching for women who grew up watching or had their mothers being beaten, or had partners who had also grown up with violence in the household, were much more likely to experience violence. Similarly, if they were abused in childhood, again, they were much more likely to experience violence. Then here there is a graph that says attitudes towards violence, and what we asked in the survey was whether it was acceptable for a man to beat his wife for any reason, and those reasons are things like refusing to have sex, if the partner suspects his wife of being unfaithful. In some settings it's about not cooking or not taking care of children properly. So for even if there was one reason which they said was acceptable or a justification for men to beat for beating their wives or partners, then it was classified as a traditional harmful gender norm that perpetuated violence, and that was found to be significantly associated with intimate partner violence. And then the other risk factor was heavy drinking or alcohol. The other risk factor that I've highlighted in sort of mild red, which didn't have a very significant effect, which is partner having, or the male partner having concurrent relationships outside the household. Okay. Just in terms of for you to see how this plays out in a particular region, which is Latin America and the Caribbean, as I'd mentioned, there is analysis that our regional office in the Americas is coming out with, which shows, and this is data from the demographic and health surveys as well as the reproductive health surveys, where if the woman's agreement, women who agree that wife beating is justified for at least one reason, there's a higher likelihood of violence. And you see that the data here show between 50% of them agreeing with this in Ecuador, down to about 2% in Jamaica. So then, talking about what is the prevention and what is the response, I think the fourth key message I'd like to give is that it can be prevented, and that prevention, what we know from a lot of the data that we're analyzing, is that there needs to be a focus on transforming attitudes or harmful gender norms, addressing childhood sexual abuse, reducing harmful drinking, and improving access to education for girls and boys. This particular graph is or figure is basically a framework which we use a lot in violence prevention programming, and it's called the ecological framework, which is basically saying that you need to intervene at all these different levels. The innermost circle here, is interventions that are needed to change the behaviors and address the individual risks. Then this particular circle is that you need to intervene at the level of couples and families, recognizing the role that men play in perpetrating violence, as well as the attitudes of families towards violence. And then this particular circle here is the recognizing the role of harmful gender norms that are held by communities, talking about the acceptability of violence, which is a risk factor. And then the outermost circle is interventions that are needed at the level of laws, policies, and national sort of and institutional responses. And what I've tried to do is give you between sort of 4 of these boxes different categories of interventions that we're beginning to get evidence of their effectiveness. The first one is data that we have on interventions that are focused on empowering women. And there are interventions, for example, that provide microfinance and gender relationship training. The most famous one of them is called the IMAGE study, which was conducted in South Africa, which was a combined microfinance and gender training intervention using a randomized controlled trial, which is considered one of the most sort of methodologically rigorous ways of doing the study. And it showed 55% decrease in violence when both these components were included. Then we have data primarily from North America with a number of evaluations that have been done which show impact of school-based programs to prevent dating violence, which have shown some impact on violence prevention. Then if you look at some of the interventions that have attempted to work at the community level, that is by changing or transforming harmful gender norms, there are interventions that have been done through media awareness. The most sort of famous ones are Soul City and Sexto Sentido, which are interventions done in Soul City is in South Africa and Sexto Sentido is in Nicaragua, which are soap operas or telenovelas, which are aimed primarily at young people, and they raise a whole range of issues that affect young people. That includes discussions around violence, discussions around healthy relationships, STIs, HIV, pregnancies, etc. And the evaluations of these campaigns have shown improvements in attitudes towards violence. Then you have community mobilization interventions. Again, the one that a lot of people I think might already know is called Stepping Stones, which has been implemented in 80 to 100 countries, and a randomized controlled trial that was done in South Africa using the Stepping Stones approach showed huge impacts in both reductions in perpetration of violence by men as well as reductions in STI risk. And this is now increasingly recognized as an important strategy for changing male norms. Then you have interventions to provide gender equality education in schools. And then down here, there are a whole bunch of programs that are being implemented to engage men and boys for promoting gender equality. And these are primarily employing peer education and participatory education to change male norms and behaviors. The ones that people often talk about are Program H, which was implemented with young men in the favelas, in the slums in Rio de Janeiro, as well as a program called One Man Can. It's a campaign done in South Africa aimed to change male behaviors, and another one in India called Yari Dosti, which is peer education among young boys and young men to change male norms. Then there are interventions also to change access to and use of alcohol, which are showing some impact, and we have evidence from various evaluations that are showing impact of that. This one here, which is the implementation of gender equality laws and policy changes, I think they're difficult to sort of show impact on using sort of the traditional public health epidemiological methods, but I think we use the human rights argument for implementing this in terms of the evidence needed. These are anti-violence laws, training of law enforcement that includes police and judges to in how to respond to the victims or survivors of gender-based violence or violence against women, legal aid services, and the need to improve forensic evidence collection, particularly when it comes to sexual violence. In terms of some of the more promising interventions to prevent violence against children, and this is where the data is not yet very solid, but we're having emerging evidence that these might be effective. One is school-based training to help children and adolescents to recognize and avoid potentially abusive situations in schools, home visitation and parent education programs, and then bullying prevention programs, including programs in schools to develop social and economic, emotional skills development, In addition to prevention, I mean, there's obviously a need to then respond to victims or survivors of violence. And what we know about improving the health sector response, and this is some of it is going to be factored into WHO guidelines on clinical and policy practice for the health sector to respond to gender-based violence. And those guidelines will be released later this year. is the first thing is that it needs a comprehensive health systems approach to respond to the needs of violence survivors, which includes policies as well as protocols for treating survivors of violence, training of all health staff in how to deal with victims of violence in a compassionate and ethical way, making sure that health services for women and for adolescent girls have in place safety and privacy and confidentiality measures, strengthening the referral networks to other services, providing emergency supplies, things like ARV prophylaxis, it could be STI prophylaxis, emergency contraception for victims who've experienced sexual violence, providing educational materials on violence against women and children, and then making sure that the health services and other services are being monitored and evaluated quite rigorously. In terms of going beyond the health sector, there's a real need to have a multi-sectoral response. I think there's a recognition that it needs to be a multi-sectoral response with good coordination between different sectors in order to provide women with services they need in a comprehensive and holistic way. And so the first one that I think is important to flag is the need to coordinate between the health and the justice systems in order to improve the medical legal services. So for example, if a woman who has experienced sexual violence comes into the health service or health setting, then there needs to be good coordination between the health services and the legal services in order to make sure that she has referral as well as the kinds of things that she will need to lodge a complaint if she's experienced sexual violence, for example. Then there's obviously the need to coordinate between the health and the education sectors on the education in schools. I already touched upon the mass media, but then there's also a need for the health services to coordinate referrals with other socioeconomic services, socioeconomic support services, recognizing that many women who experience abuse are often sort of stuck in abusive relationships because they may not be in a financial position to leave abusive relationships. So you need to have referral mechanisms to other economic services that provide economic support. I don't know how much time I have. If I have a little bit more, I can, yeah? Okay. So just quickly, sort of the last set of slides I have, touch upon some of the work that we're doing in WHO. And our priorities are really centered around three things. The first one is really around generating the research and evidence needed for advocacy and needed for policymakers to put in place sound measures for violence against women and children. The first one, as I said, is the Global Burden of Disease Study, which will include estimates of death, illness, the disability-adjusted life years due to both violence against women as well as child maltreatment. And part of that will also include estimating the health effects of violence against women and children. That includes low birth weight, prematurity, STIs, mental health and injuries. Then we're also doing a study in South Africa and Mozambique to look at what might be effective interventions to address violence against women in antenatal care settings. And the rationale is recognizing that many women experience violence during pregnancy as well as seek care during pregnancy, antenatal care during pregnancy. So it provides an opportunity and an entry point to introduce some intervention around violence. And we're going to adapt a intervention that has been done in North America and found to be effective in low-income settings like South Africa and Mozambique. And the study in South Africa will be starting soon with the sort of formative research phase. And based on that, then there'll be a randomized controlled trial. Then there's another study that is being done in the Philippines on adverse childhood experiences and the lifelong impacts that those have on the well-being of children as they mature into adults. And as I said, we've been doing a lot of ongoing analyses of the WHO multi-country study. The one that we are now going to be putting out soon will be on risk and protective factors for violence against adolescents, as well as the emotional abuse, its prevalence and health impacts. In terms of the second priority that we have is on developing norms and guidelines in terms of how the health sector should respond to violence against women. As I said, we'll be putting out later this year clinical and policy guidelines on health sector response to violence against women. And we have already, which I think is outside, this blue book, which is the guidance on primary prevention of intimate partner and sexual violence. And we've also put out a publication based on the evidence on interventions to address violence against women in the context of HIV, which is this particular publication, which is also outside. We're also doing reviews of data on violence against sex workers and the impact that has on STI risk and condom use among sex workers. We just had a meeting last month with community-based organizations implementing interventions to prevent violence among sex workers, and we'll be developing some guidance around that. And we'll be putting out a programming guide to address violence against women in the context of HIV. Then in terms of some of the work that we're doing on country support and policy development in countries, we're building capacity, for example, by working with the Mahidol University in Thailand on a course on how to research violence against women. We've been doing a lot of workshops on primary prevention of violence in Eastern Africa and some of the Western Pacific countries. And we're also working in Malawi and South Africa on policy for child maltreatment. And we have training courses that we're developing and implementing on child maltreatment and violence against women. So just to conclude, some of the take-home points that we have, I think, just to sort of reiterate the 4 key messages that I had throughout the presentation, that it's widespread, that it has serious health consequences for women and girls. I also touched upon the fact that it has intergenerational consequences affecting children and families, and that it has considerable economic costs. But it is, I think, sort of amidst all of that very, I think, depressing statistics, is now the knowledge that we have the tools, we have the evidence, and we have the interventions that violence against women can be prevented. But in order to do that, we have to promote gender equality, and that it requires multidisciplinary action. So thank you all. And if you need more information, here are some contact names and email addresses. Feel free to come to me if you want more information. This is a joint effort in WHO across several departments, including the Reproductive Health and Research and the Department of Violence and Injuries Prevention.
Okay, Avni, thanks very much. I think that that was a very comprehensive presentation, and a couple of things that struck me. First of all, as we had suggested, the statistics are startling and worrying and despairing in ways, and the nature of the way that gender-based violence is culturally embedded is something that's clearly going to take a long-term intervention or long-term interventions. And that includes the attitude of women as well. But I think there's great indication of the success that intervention can have, and this multidisciplinary approach that's required. But real impact can be made, and real success can happen if we focus our work in the right way and we involve the right stakeholders and are committed to it. So I think it's been an excellent presentation, but I'm sure that there are plenty of people from the floor who would like to ask Avni some questions or maybe make some comments. So it's open to the floor. Great, we have one to start off with. If you could just introduce yourself, maybe say where you're from.
Hi, thank you very much for your very informative presentation. My name is Elaine. I'm currently doing an MPhil in Peace Studies in TCD, but my own background is actually in social services and child protection. I just wanted to ask you, I noticed some of the statistics between the urban-rural divide on the prevalence of gender-based violence. And in my experience, I feel that services are very much centralised, especially in Ireland. Yeah. And being from a rural community myself, there can be barriers to access in terms of transport, economics, and of course the whole thing of being a rural community, everybody knows who you are. So I was just going to ask you, what would your policy recommendations be for the provision of services in rural areas? Thank you.
Maybe if we collated 3 or 4 questions and then Avni might take from there.
Hello, Finola Finnan from Throcra. I should stand. Thank you very much for that very interesting presentation. And I was particularly interested in your combination of strategies, the strategies that we know to be effective. And you presented 4 main categories there. And I suppose my main question is, how much do we know about the combination of strategies that work? And how many of those we need to be effective? And then just a second question, I'm interested in the work on alcohol. And again, maybe you could talk a little bit about what works on that. Yeah.
Okay.
One more at the back.
Yeah.
One more.
Sharon Jackson, I'm an independent scholar and also at Trinity. Thanks for a fascinating presentation. I was just wondering about, you talked about the intergenerational aspects, and I think you also said it was much more likely for people who have witnessed abuse or who have experienced abuse as children to either be perpetrators or experience abuse later in life. And I was just wondering if you could go into more depth in terms of what is the strength of that relationship, what kind of proportions are we talking about, and what is the evidence base fairly broad for that at this stage, or are we still relying on a couple of studies? Thanks.
Yeah. Okay, maybe I'll just start with the last one first. In terms of the intergenerational consequences, I didn't show one slide which is analysis done from the 10 countries that are participating in the demographic and health surveys. I deleted it in the interest of time. But just to say, across those 10 countries that participate in the demographic and health surveys, it was a very consistent association with almost a 3-fold increase on an average across different settings, where if you had a history of witnessing abuse or having experienced childhood sexual abuse, you are much, much more likely to experience intimate partner violence. I can later on pull up that slide. It's saved somewhere else. I can show you that slide. But it's one of the strongest pieces of evidence that we have, apart from the history of alcohol use. Then I think in terms of the combination of strategies, the second question that was asked, I think what we know is that we need combination approaches, and the image trial that was done in South Africa very clearly showed that if you had microfinance alone or gender training alone, it didn't have that much of an impact. But if you had those two combined, it had a much, much more significant impact. Having said that, I just wanted to say that with respect to the evidence on prevention, we are really, I think we're sort of just still beginning to have emerging evidence on what is working. And we don't really know for sure which combination of all those 4 categories that I outlined are likely to work in what settings. I think we're sort of still at the stage where we're identifying, how to fill out those boxes and at what level do we really need to intervene. But having said that, I think we can very confidently say that you really need to have multiple strategies at a time and operating at all those different levels of those circles that I outlined. But it's difficult to say that, transforming male norms in one setting combined with microfinance, combined with a particular law policy is going to be effective globally. I think the other thing to also factor in is that in each country and each context, you will have a different set of combination of interventions that will need to be applied. So that's sort of for the second one. Then, then you also asked about alcohol. And I think what we know about the interventions done to reduce alcohol-related risks is really reducing the access to alcohol through various mechanisms, taxation, different policy mechanisms. And most of them, I think, are outlined in this blue book in much, much more detail. So you can sort of go through that because it's listed as one of the more effective strategies. And then in terms of some of the policy recommendations for rural areas, I think the difficulty is, and I'm sort of coming at it from a low to middle income country setting, that we are actually struggling with even availability of these services in urban or rural areas. I mean, if you take a country like Kenya, there are hardly, maybe one, maybe two in the entire country, services or shelters for women who've experienced violence. So I guess even when we talk about the urban-rural divide, we're sort of not even there, because most of these services are not even in place in most of these countries, regardless of urban or rural. But obviously, I think the challenges for the rural areas will be exactly what you said, which is the transport, the costs, the stigma around seeking services. Because you obviously don't have that anonymity that you have in urban areas. And I mean, we don't necessarily have policy recommendations that are specific to rural areas. What we're coming out with is policy recommendations for countries to just begin to put in place what they should be doing and what is the evidence for that. So I'm sorry I don't have something more specific, but I think we're at a very, very preliminary stages of recommending interventions to countries.
Yeah, I think we might have time for one or two more short questions, and then we'll move on to the next presentation. So perhaps there are one or two other comments. Don't be shy. No? Yes. Hey, there you go. going. Here you go.
I'm Gillian Wiley from Peace Studies in Trinity. I suppose I was just really interested to hear a bit more about the methodology behind the surveys. Because as you said during your presentation, these data are very hard to get. And I was just curious to know a bit more about how you got them.
Mm-hmm.
Yeah, I'm Kenna from Trinity. Just something about the interventions that you mentioned. I think 4. You mentioned the question of policies, kind of transforming norms that seem to be kind of promoting destructive practices. Question of empowering women. And then you mentioned that maybe what needs to be done about men is to engage them, men and boys. But I think there's something more to just engaging them that needs to be done, because, I mean, how do you engage people who are involved in drinking problems that are actually leading them to carrying out violence against the women? I think there's something more than just engaging. Maybe something like the same terminology that you're using of empowering these men, to let them realize what they are doing that is actually leading them to do what they are doing. Yeah, just a comment.
Yeah.
I was very interested. Sorry, I'm Marlene from Trinity College as well. I was very interested in your comment that gender-based violence can be prevented, and there are surveys that show that it can be prevented, and how the research is done around those prevention programs, especially how you decide where prevention programs are implemented and where not.
Okay. Should I take this set? Okay. So just 3 questions, more or less 2 of them are around methodology, so I'll try and address them together. In terms of the methodology behind the surveys, the survey methodology was developed for the multi-country study. At the WHO multi-country study, we developed the methodology of the surveys with the set of questions, and I'm happy to share that with you. It's very specific on asking women not that whether they've experienced violence, but about specific acts of violence that they've experienced. And then these surveys were done with usual sort of survey methodology in these 10 countries. In addition, the data that we have for the global burden of diseases estimates is also that similar surveys were done and are being done by the Demographic and Health Surveys, which is this big, huge apparatus of the US government done in many, many countries around sexual and reproductive health. They have questions on family planning, HIV, testing and counseling, etc. And in select countries, they have a module with a similar set of questions that we have in the multi-country study on violence, and it's called their domestic violence module. So in select countries, they on a repeated basis implement the violence against women module. So you have estimates from that. And again, the questions are fairly similar. Have you experienced in the last 12 months or prior to 12 months, and from your current intimate partner, hitting, slapping, pushing? Have you been forced to have sex when you didn't want to? There's a list of items on emotional violence. And then then you have the International Violence Against Women surveys, which I think are being implemented in about 15 countries, primarily middle and high income countries, again with a sort of similar methodology. So what we've done is, for the global burden of disease estimates, we have pooled the prevalence estimates. We've more or less established that the data are comparable, and they're measuring more or less the same thing, and so we've pooled that data, and that's how the estimates have been derived. And this 10 years ago was not possible, but given all the work that's been done on this, 10 years later, we have a fairly robust set of studies and surveys. And just to sort of add to that, as a result of this, we have finally asked within the UNAIDS core set of indicators that countries are asked to report, we're going to be asking countries to also report on violence against women as a marker of gender equality or gender inequality. And that's because countries are collecting this data in a standardized way. Not all, but many. So then in terms of the methodology for the interventions, what we've done, some of it is in this particular book, but we've sort of commissioned what I call systematic reviews, and they're sort of, you do the searches in your all the different databases that you can find with a certain set of criteria on a particular area of intervention. So if it's alcohol, then you'd sort of go and do the searches. And where the studies have been evaluated and where they meet certain rigorous criteria for inclusion, where there's data pre and post, there's a comparison group, etc., then we kind of include those. And based on that, we've been able to come up with some estimation or idea of effective interventions. And where you've had more than one review on a particular topic, like alcohol, if somebody's done more than one systematic review, then we say that the evidence is even more compelling, and then you kind of make that as a recommendation. So we've used that as a way of scoring or making our recommendations. And that's sort of now in WHO become a standardized practice, that when you make a policy or a program recommendation, you need to base it on these systematic reviews of interventions and see what is working. So that's what we've done. Now, in terms of the engaging men and boys, I think your point is well taken. I'm using a terminology that we've globally been using as a way, it's a euphemism for really what is interventions that are working with men to change norms and practices, whether it's around alcohol, whether it's around promoting, sort of more positive images of masculinity. And that most of these are not engaging in that very euphemistic way. They're peer education, participatory interventions that are working with young men. I mean, Program H is one of the most sort of famous ones that was initiated, based on which all the other interventions on working with men have evolved. And they're very, I think engaging, you're right, it's a very euphemistic way of describing what it is. It's really working with men and boys to change behaviors and practices. I mean, it's essentially that. And the methodology is very participatory, and it touches upon everything to do with things that affect men and concern men, about their own health and well-being, to their own sort of roles and responsibilities vis-a-vis women. So your point's absolutely well taken. So I'll have to go back to the global community that works on this, and we'll have to find a better term.
Okay. I think we're going to have to wrap up there, because we have another very interesting speaker coming up next. Could I once again, on behalf of all of us here, thank Avni for a very comprehensive presentation and a great discussion. I'm going to hand over to Eilish now, who will chair the next session.